Hello everyone. So today we're going to talk about uterine fibroids. I'm just going to give an overview of what they are, the treatments, and the various options a person has when they have fibroids. So let's start off by just going over what fibroids are, where they arise, and what causes them. So fibroids are the commonest type of uterine tumours. Now the word tumour usually makes people nervous, but you must remember that whilst a cancer is often referred to as a tumour, it's only one type of tumour. The word tumour medically just simply means swelling. Fibroids in themselves do not become cancerous. They are benign, and the symptoms they cause are because of pressure and because of their location in the uterus. They occur in about 70% of women during their life and can be treated in many ways. Now, there is another tumour that arises in the uterus known as sarcoma, which is cancerous. And the risk of that happening is 7 per 100,000 women. So if you compare the risk of fibroid against the risk of sarcoma, you'll see that the risk of sarcoma is actually very low. So what causes fibroids? We know that race is a significant factor. They're commonly in the Far East, Middle East, Sub-Saharan Africa, and South America. The risk of fibroids also increases with age. We also know that fibroids are fed by estrogen, so an early start to the periods or a greater number of children, because estrogen is higher in pregnancy, increases your risk of fibroids. There's also a hereditary component, so genetics plays an important factor in the risk of fibroids. If your mother had fibroids, you're at a higher risk of getting fibroids. Caffeine and alcohol can increase your risk. Obesity also increases your risk, probably because of higher estrogen production in the fat cells, and maybe because of other factors. Some medications increase the amount of estrogen in your blood and therefore increase your risk of fibroids. These kind of medications are ones, for instance, used in assisted reproduction. If you're trying to have IVF or something like that, some of the medications given will stimulate growth of the fibroids. Fibroids can grow or get smaller, such as during pregnancy when the estrogen level is high, and then after delivery when the estrogen level drops down. If they're small and don't give any symptoms, they don't really need treatment. If we're talking about treatment, there are only two proven indications for treatment of fibroids. One of those is abnormal uterine bleeding, such as heavy periods, and what are termed bulk-related symptoms, such as pressure or discomfort. For instance, a big fibroid sitting on top of the bladder will cause urinary frequency and discomfort in the pelvis. Now, the unproven indications, ones we think it might help, but there have been no reliable studies to confirm their benefit, are treatment of infertility, prevention of obstetric complications, and evaluation of uterine or ovarian malignancy. So just like many things in medicine, fibroids are classified into different types depending on their position in the uterus. Some are pointing inside the uterine cavity and they're called submucosal fibroid. Some are positioned on a stalk on the outside of the uterus and they're called pedunculated fibroids. These are the two extremes, and then the various types of fibroids in between, as you can see in the diagram here. So let's talk about treatment of fibroids. There are basically 4 treatment options, and I'll discuss each one as we come along. Expectant management is basically where there is no treatment given, but you're reviewed periodically to assess the symptoms and the size of the fibroids and to see if treatment becomes necessary. The other 3 options are medication, what are called interventional radiology, which is basically treatments for the fibroids that are usually carried out in a radiology department, and I will go through these, and surgery. So let's look at medication. Now, you can have 2 types of medication. You can have hormonal or non-hormonal. Non-hormonal is simpler and have less side effects. The commonest non-hormonal medication is a combination of something called cyclocapron or tranexamic acid with Ponstan, which everybody knows. The idea is The cyclocapron stabilizes little clots at the end of the blood vessels to reduce the bleeding, and upon stun improves the pain. And together they have what is known as a synergistic effect, so they have a better effect than when they're used on their own. The first of the hormonal medications is the progesterone-only pill. Now, the progesterone-only pill is standard pill that's used for contraception for ladies who are breastfeeding. It works by maintaining a very thin lining to the uterus. So if it's used in situations where there's heavy bleeding, the idea is that it keeps the lining very thin and you get very little bleeding with your periods. Obviously, you can have the combined pill, because we know the combined pill generally improves bleeding with the periods and it improves the pain. The next option is something called GnRH analogs. Now, the idea is that the hormonal production by the ovary is stimulated by hormones from the pituitary gland in the brain. These medications suppress the production of the hormones from the pituitary gland that will get the ovary producing the estrogen and progesterone. So they're very strong medications. It gives you basically a temporary menopause, so you'll have the side effects. But you can use it with something called add-back therapy, which works basically as HRT. So you don't get the side effects of the menopause, but you'll still get the benefit from this medication. The last option we have is something called Esmia. Now, Esmia is something that we've been around for a few years, and when it first came out was really promising. It shrinks the fibroids very well and has a longer lasting effect. But we now know that it can affect the liver. And because it can affect the liver, the current guidelines say it can only be used for 3 months. And if you use it during that time, you need to check your liver function at the beginning, halfway through, and at the end of treatment to make sure that everything is okay. So, if we don't use medication, the next option is interventional radiology. And this is in the form of what is known as uterine artery embolization, where we block the blood supply to the fibroid, so we kill it off, and basically the idea is that it dies and shrinks to around half its size if the treatment works. And we have a newer technique which is known as HIFU, which is high intensity focused ultrasound, and that basically is carried out in a radiology department with an MRI machine and an ultrasound machine, and we direct the ultrasound waves at the fibroid to try and break it down. So, as I've said, with the uterine artery embolization, a catheter is fed in to the thigh. It goes around the blood vessel and around the femoral artery down to the blood supply of the fibroid itself, and then some particles are injected to block this, and then the catheter is taken out again. So what are the results following treatment? Well, there's a 30 to 60% shrinkage in the size of the fibroid. It means a shorter hospital stay. It is thought there is less pain following it than following surgery, but you have to remember this is dying tissue that's left in the body, so it can give a little longer pain even though it's not severe. And patients who have this carried out should be able to return to work fairly quickly. With the high intensity focused ultrasound, this is the MRI machine, and then you have an ultrasound probe underneath the bed. You direct the beam at each of the fibroids, and it's supposed to break down the fibroids and allow improvement in the symptoms. Now, the results for this are similar to ultrasound. I've got a little diagram of where the fibroids are so you can understand the reference to the fibroids as we'll make them. There's a 40% reduction in the volume of the fibroid. It can be done in the outpatient setting. Usually you don't need to stay overnight. It's not suitable for what are known as type 0 fibroids, which are the submucosal fibroids here, because you end up with dead tissue sitting in the uterus. And you can't really do it if there's an intervening tissue between you. So for instance, if there's intestines here, you can't direct the ultrasound beam through that. and not suitable for fibroids that are bigger than 10 centimeters or more than 5 fibroids. So we've talked about medication and we've talked about interventional radiology. The next option is surgery. Now, the simplest surgical procedure you can have for fibroids is known as a hysteroscopic myomectomy or transcervical resection of the fibroid. Basically, this is for fibroids that are pushing in on the inside of the uterus or hanging on a stalk inside the endometrium. In these cases, you can put a telescope in via the vagina into the uterus and cut or shave the fibroid out. For fibroids that are more accessible via the abdomen, the most common procedure nowadays is laparoscopic myomectomy. This involves very small cuts in the abdomen, 3 or maximum 4, where you put a telescope in and then just some instruments. You open the uterus, remove the fibroid, and then repair the uterus. You can also have this carried out as an open procedure with a bikini cut or a midline cut. In both cases, this would be usually for very large uteruses where laparoscopy to remove the fibroid may be dangerous, or where there are many fibroids where it can be accessible and carried out laparoscopically, but may mean an operation of 6 or 7 hours as opposed to 2 or 3 if it's done as an open procedure. So the long-term risk to the patient's health would be better with an open procedure. Once options for myomectomy have been considered, the next possibility is what's known as hysterectomy, which is removal of the uterus. Now, it can be done where you remove the uterus but keep the cervix, or you remove the whole uterus including the cervix. In both cases, the ovaries are left in place, so there should be no hormonal effect following the procedure. It can also be done as an open procedure if there's a very large uterus, again, because laparoscopy would be unsafe in that situation. So let's talk about laparoscopic myomectomy. It's quicker recovery following the procedure. Patients have to be selected appropriately for this. It's only really suitable for symptomatic fibroids. You can't just do it because you've seen a fibroid. That would be, unethical. And it can be carried out if you're carrying out a laparoscopy to treat other issues, such as endometriosis or adhesions. First step is to get an accurate assessment of the fibroid, as we said, with an ultrasound or an MRI. This scan can show if there are other problems as well. It can show us if there's, for instance, a large ovarian cyst, if there's severe endometriosis and the back of the uterus is stuck to the intestines and therefore could make the procedure more difficult and higher risks. It gives you a chance to plan the surgery, and it also confirms the fibroids are there and the size of them. Now, when you go in for surgery, as I said, you have 3 or 4 cuts. So the first one is you get a little cut, as you can see, it's about 1 centimeter on the inside of the belly button. And then you get another cut here, which is about 11 millimeters as well, and a third cut here about 5 millimeters. You may get a 4th one there. Occasionally, if you've had previous surgery and you've got big scars along the abdomen here, or the strong risk of adhesions, we don't want to increase the risk of the bowel damage when we put in a telescope in. So we put the first entry in at the point called Palmer's point, where we use a very small telescope to go in so we can look underneath the belly button here and insert our scope safely. Now, I won't put up any videos of the procedures because people may not want to see it, but if you do, please let me know and I'll be happy to post them. Just going through images, this is a fibroid on the uterus, and we've done a laparoscopy to go in and get this fibroid. This is the uterus below, and you can't see it there, but there's one ovary at the back there and there's another ovary here. Okay, so you go in, you assess, you inject some fluid in to reduce the risk of bleeding and lower the amount of blood in the uterus. Then you use cautery to open the uterus, identify the fibroid, Once you identify the fibroid, it's just a case of shelling it out very, very carefully. There's usually an area between the fibroid and the muscle of the uterus which doesn't have much blood or blood vessels, and therefore you can take the fibroid out with very little bleeding. Once the fibroid is completely out, then you just cauterize to make sure there's no active bleeding, and then we suture it to settle things down. Thank you very much for watching. If you have any questions or there's anything you want me to clarify, please let me know. I'd welcome your comments below.